Presenting on urinary tract infections today. So as we know, the urinary tract consists of the kidneys, ureters, bladder, and the urethra. This is usually a sterile system, but when bacteria is introduced, usually we urinate and it flushes out the bacteria, but sometimes that doesn't happen as effectively as we would like, so it causes an infection. There are two types of UTIs, uncomplicated and complicated. Uncomplicated, as you can imagine, is when the patient is relatively healthy and doesn't have a bunch of different past medical history. So no diabetes, renal disease, neurological disorders. This includes patients that are not pregnant, and this happens to present about 2 to 3 days after the invasion, and the bacteria can come into the urinary tract several different ways, which we'll get into. And then complicated UTIs occurs when the patient does have an underlying disorder, as we talked about. So that would be the renal, the metabolic, or the neurological diseases, or the patient is pregnant. And this can include the upper urinary tract as well. So uncomplicated will have the lower urinary tract, the bladder and the urethra, and the complicated can be just the lower, but it can also include the upper urinary tract as well. The complicated UTIs usually lead to antibiotic failure, and as you can imagine, we see more complications with that. So this would be like the pyelonephritis or sepsis. Okay, so etiology. So about 70 to 95% of UTIs, so the majority will be caused by E. coli entering the urinary tract. There is a small percentage that is caused by STIs, so that would be herpes, gonorrhea, chlamydia, mycoplasma, that can also cause UTIs, but we will see more of a urethritis with the STIs versus the cystitis or the pyelonephritis from the E. coli. So we see this happening because of bacteria is being introduced from the digestive tract or from like vaginal pH imbalance to the urethra. So this is happening by improper wiping or after sexual intercourse. We'll get more into that with the risk factors, but so bacteria is being introduced from a different part of the body into the urethra and is being adhered to the bladder wall, causing a UTI. Okay, so risk factors. So as you can imagine, women do get UTIs much more than men. This is because our urethras are much shorter than men. So the bacteria don't have to travel as far. If you have a history of UTIs, especially several, you're just more prone to them. And age. So we have older adults that are more prone to UTIs. This is because this is where we start seeing more dribbling or incontinence. So you have adults wearing incontinence briefs or peri pads, and they're not changing them super frequently, so it just introduces that bacteria a little bit more easily. And then we have young children. So if you can imagine young children that are trying to body train, they're trying to start to shower themselves, their hygiene may not be perfect, and they're just starting to get used to wiping themselves and such. So they are a little bit more at risk for UTI. And then we have the age factor for menopause. So women that are going through menopause, perimenopause, or postmenopause have changes in that vaginal flora. So that makes them more susceptible to UTIs. Pregnancy. So when you're pregnant, the baby is putting pressure on that bladder in the urinary tract. So that's causing trapping of bacteria and can lead to infection. So usually once birth, after birth, once they are no longer having that pressure on the urinary tract, they're not as susceptible to UTIs unless they've already had a bunch of UTIs in their past, and they have a higher chance of getting more. We have structural abnormalities. So in men, you'll see the men with enlarged prostates. have more UTIs. This is because, as you can imagine, we're not flushing out that urinary tract system as effectively or as frequently. And then you have our patients with kidney stones or certain types of cancers that can put them at higher risk for a UTI. Sexual activity, so this is the introduction of bacteria after sex. This may increase the risk of UTI, especially with the use of spermicides. And then especially if you have a change in the vaginal flora, that puts you at a little bit higher risk. And then, of course, as you can imagine, hygiene. So if you're not able to shower as frequently, or if, like I said, you have incontinence briefs or a peri-pad, that can put you at higher risk for a UTI. So symptoms of a UTI, this is going to be different for wherever is infected. So lower UTI symptoms versus upper UTI symptoms are going to be different. These are a list of the generalized symptoms. So dysuria, so pain with urination, frequency, especially frequent urinating in small amounts, cloudy urine that is discolored from usual, so you're red, pinks, or cola colored. And then, of course, it's going to be malodorous, and you may have some pelvic pain as well. That's more common in females than males. But so depending on where it is, so if it's urethritis, so the urethra is infected, you're going to have more of the burning with urination, and you may see discharge as well. If it's the bladder, which is the most common, so this is also what we know as cystitis, you're going to have the pelvic pressure, lower abdominal discomfort, frequent painful urination, blood in the urine. This is the most common, as I said, and is the what we imagine a UTI would feel like. And then, of course, we have the upper UTIs, so the pyelonephritis, the kidneys, and then we have like bacteremia, and I'll go over that in just a second. That's more of our red flag symptoms, so that would be closer to sepsis. So red flag symptoms, so we would want our patients to get help immediately if they're confused, if they have nausea, vomiting, fever, chills. Signs of pyelonephritis would be back or flank pain, high fever, chills, nausea, vomiting, as I said. And then sepsis and bacteremia, that's when you're going to start seeing the sepsis protocol. So the hypotension, the tachypnea, back pain, tachycardia. That does say back pain. My face is just in the way, but so these are the symptoms that we would start being like, oh, something's definitely wrong. They should probably admit it, and they should probably go through the sepsis protocol. So physical exam, what are we going to look for when these patients come in? So for a UTI, there isn't really a physical exam that we would have to do necessarily. But we do want to do vital signs. And if this patient is very sick, or if we're kind of on the line of what is causing their symptoms, we should do a physical exam. So vital signs, we'd want to look for the tachycardia, fever, hypotension, anything that would give us a red flag symptom. Inspection, so if they're pale, diaphoretic, just give them a once over, especially when they walk into the room, see if they're able to be upright, if they're very sick, if it kind of sets that red flag off in your head. We'd also want to look for any obvious abnormalities of the abdomen or the flank area, just to make sure that if there's no trauma or any obvious masses or anything like that that would be causing their pain. Palpating the abdomen, especially the lower abdomen, if you can palpate the bladder, maybe they're holding on to urine, and maybe they have an obstruction which caused the infection. So anything that you feel like would be necessary depending on how they're presenting. And then percussing, so if you feel like your patient comes in with the prostate issue and they're not able to urinate, you can percuss the bladder or the kidneys depending on if you feel like it's a complicated UTI. But uncomplicated UTIs, there isn't really a physical exam. You can get a set of vitals, but it is usually based off of subjective information and our laboratory diagnosis, which we'll go over here in just a second. Differential diagnoses, so these are the list of them, very common. So acute pyelonephritis, which we had talked about, an STD such as chlamydia or herpes, cystitis, bladder cancer, pelvic inflammatory disease, urethritis, or vaginitis. So these are all presenting with the lower abdominal pain, burning with urination, discomfort with urination, blood in the urine. So there is a lot of different diagnoses that can present in the same way. So this is how we will diagnose them with our diagnostics. So diagnostic-wise, usually the uncomplicated UTIs can be diagnosed with just a dipstick urine, but you can do a dipstick, a urinalysis, and a culture. Imaging studies aren't usually indicated unless a stone is suspected. So dipstick is the most common and gold standard. In most cases, it would show a positive leukocyte esterase, and usually that can just be the end of the line. But if this is like their first UTI, or you feel like it may be complicated, or even if the dipstick is negative and they're still symptomatic, you can do a urinalysis. The urinalysis is a clean catch, so that's when we would do the 3 wipes to really make sure that the area is clean and it's a clean catch. So it would be midstream. So education is really important with the urinalysis, but it can also obtain a urine through catheterization if needed. So the urinalysis would show leukocytes, microscopic hematuria, which is about half of the cases would show that. Low amounts of protein is very common, and positive nitrates are highly specific for UTI, but only about 25% of the cases actually show it. But if your patient comes in and they have nitrates in their urine, that's usually a pretty high indication that they have a UTI. From the urinalysis, depending on what it shows, a culture may be indicated. This is usually performed for patients with immunosuppression or a recent UTI that could be caused by a different bacteria, or if they've had recent antibiotic use or advanced age, something that would make you seem like maybe this could be used by a different bacteria. And then a CBC for a complicated UTI, if you want to see their white count and just see if they are going towards sepsis. But that's usually not indicated, but it is something that can be done to help with the diagnosis. So depending on what we find with the cultures will help us determine which part of the urinary tract system is actually infected. So if you have about over 1,000 colony forming units, that's cystitis. So that would be your lower urinary tract infection. It is confirming that. If it's over 10,000 colony forming units, that are indication that it's probably pyelonephritis and it has moved up the urinary tract. And then we'll be looking at bacteriuria if it's over 100,000. So that's closer to sepsis and would need more emergency treatment. So how do we treat a UTI? So non-pharmacological treatment, there isn't really anything to necessarily treat a UTI at home, but there can be some adjunct therapy to kind of help your antibiotics work. So this would be drinking lots and lots of water. They recommend minimally 6 to 8 ounce glasses of water a day. Stay hydrated, keep flushing that system. Cranberry juice doesn't treat a UTI, but it does help prevent bacteria from attaching to the lining of the bladder. So this is more of a prevention, but they do recommend drinking it with the UTI just to help further spread. And then a heating pad on warm, not hot, can help decrease the pain or the pressure of the bladder. So pharmacological treatments, the only way to treat a UTI is with antibiotics. So our first line treatment for non-complicated UTIs is the Bactrim DS or Septra DS. And that's going to be a 3-day treatment. So 1 tablet twice a day for 3 days. Alternative treatments are the macrobid, the macrodantin, or the Monural, which is the phosphoromycin, which is over there that you can't really see. So most of those, so gold standard is the Bactrim. The macrobid will be 5 to 7 days, twice a day. The macrodantin is 4 times a day for a week. And then the phosphomycin is a one-time dose of 3 grams. If your patient can't tolerate those medications, then second line therapy, we'd go to Cipro 250 for 3 days, twice a day. So usually they can treat with that, but they can also use the Cipro XR, Levaquin, or Aflatoxin. I found the chart was very helpful to see what the dosing is and what you can educate your patients about with the adverse effects. But just to review, the Bactrim is the #1 wanted treatment, or the gold standard treatment, I should say. Okay, so most important thing with the UTI, we want to treat their symptoms with ibuprofen and Tylenol, and then we want to treat their infection with antibiotics, but the most important thing is we want to prevent them from getting another one. So education is one of the most important things for our patients at this point. So we want to push prevention with our patients. So we want them to stay hydrated, 6 to 8 glasses of water a day, as I had stated before. Keeping hydrated is really going to flush out that system and deter any bacteria from invading. Proper hygiene. So as I talked about before, we want showers regularly. We want women wiping from front to back, changing those incontinent briefs or peri pads, even toileting schedules, just to make sure that there are no bacteria that's just being introduced. Not holding urine for a long period of time. So especially someone that has a job like nurses that can't necessarily go to the bathroom at a regular schedule, really pushing towards that change in behavior and making sure that they're not holding their urine for a long period of time. And supplements. So we kind of went over this a little bit before, but cranberry supplements are a great way to prevent UTIs. As I had stated, it decreases the bacteria from being able to adhere to the bladder wall. So that's great supplements for someone that has recurrent UTIs. And then of course we can have the topical or vaginal estrogen for the perimenopausal or postmenopausal women. In fact, vaginal probiotics if the UTI is caused by the vaginal pH imbalance. And then, of course, we just want to make sure that they recognize the signs of UTIs. So if they start having dysuria or frequency or anything that may cause them to have like a red flag, like, oh no, the UTI is coming back, we want them to come in sooner over rather than later, especially if they had sepsis or something from the UTI. So that's my presentation on UTIs, and I hope you guys enjoyed.